first speaker, and that's Martine Shareck. Martine is a Banting Postdoctoral Research Fellow in the Division of Social and Behavioral Health Sciences at the Dalla Lana School of Public Health. She has a PhD in Public Health from l'Université de Montréal and recently completed a CIHR fellowship at the London School of Hygiene and Tropical Medicine in the UK. Her research interests are in the socio-spatial determinants of health equity, and specifically she draws on social epidemiology, geography, health promotion as concepts to better understand how individuals interact and engage with the urban environment, how this leads to health inequalities in health and health behaviors. And you can get more details on her website, which I will actually post a link to in the chat box right now. And with that, I will turn it over to Martine.
Great. Thank you, Dianne. Can you all hear me well?
Yes, you're great.
Yeah. Okay, awesome. So good afternoon, everyone, and thank you so much for joining us in this webinar today. I guess my task for today is to introduce the classical and the less classical entry points for intervention in health promotion practice, and to discuss the shortcomings and the advantages that they have in harnessing the social context of intervention, and also the shortcomings and advantages they have for addressing health inequities. So I'll talk about issues and risk factors, populations and specific groups, as well as settings, and then introduce the collective lifestyles approach as an alternative to these three more common entry points to intervention. So in health promotion practice, the classical and most common entry points for when developing interventions are issues and risk factors such as diabetes, HIV/AIDS, or behavioral risk factors such as smoking. Populations or specific groups, so we can think of children, women, indigenous communities, as well as settings, so schools and neighborhoods, for instance. So depending on which of these entry points we favor, the interventions that will be derived will likely be quite different. So let's say the aim is to reduce smoking in youth from low-income neighborhoods. There's already three very different entry points that we can choose from. So we must ask ourselves, where do we think the problem comes from? Is it to do with smoking itself, with the characteristics of youth, or with the settings in which they live and learn? So we need to ask ourselves these questions and think about the different entry points to intervention because they influence how our problem is framed and what we think shapes health and disease. It also influences how we should analyze and understand a problem or a given issue, and consequently what can be done about it. So what should we intervene on and how? So ultimately, our choice of entry point reflects our assumptions that can be implicit, but are most often they can be explicit, but they're most often implicit about what causes a given health problem and what can be done to fix it. And these discussions and decisions that we make about entry points for intervention, they also directly tie into health promotion competencies. So for instance, what we measure at the problem identification and the needs assessment stage will further impact program development, implementation, and evaluation. So these questions are especially important given that health promotion interventions today are generally characterized as being complex and ecological. They involve multiple levels, sectors, and components of action. They seek to change individuals, communities, organizational structures, and policy, and most often they seek to change all these things at once. And they're not universally generalizable, so there's no one-size-fits-all intervention. So we argue in this book chapter is that the social context of intervention is actually quite crucial to understand. Now, what do we mean by social context? I know it's a loaded term. It's often defined as a long list of social, political, economic, environmental, and other circumstances within which things and health happens. And it's often seen as sort of background noise that we should control away. And although being aware of these circumstances can tell us what about context matters, it does a pretty bad job at telling us how and why these things matter. So to move past this rather the common but rather limited definition of social context, we offer another one, which you can find here on my slide. I understand it's a bit of a mouthful, so I won't even read through it, but I think that the keywords here to remember are those that I bolded. So the social context involves social agents, so people, objects or things, and the interactions between them, as well as mechanisms which lead to observable outcomes. So attending to the social context of intervention requires that we pay attention to individuals, to interpersonal relationships, and to relationships between individuals, objects, and structures, as well as to the overarching institutional, social, and political drivers of social inequities in health. So one question we could ask you for now is, what challenges do you face in considering the social context in your health promotion work? I think you can type in your answers, and Dianne will probably read through some of them, if I'm correct.
Yes, you can type your answers directly in the text box. I'm just writing type your answers here. And they will appear. So we're going to take a few minutes here we really want to learn from you. What are some of those challenges? So poverty, housing, food security. So definitely those common determinants of health that we hear about. Lack of affordable housing, yeah, geographic distance, systemic racism, which is absolutely one of those deep embedded structural determinants that can affect so many things. Cultural differences, knowing when to create different programs for each SVOH. Hesitance to step on other sectors, other government department toes. Oh, that's a really interesting one. Keep going. Keep adding some things in. We'll give it a few more seconds. Conservative political environment. This is really, really interesting. I think we're getting some really interesting things here, and it'll be hard for everyone to read through. What we'll do is maybe we'll send everyone, we can share the results of this after the webinar. We can compile some of the main results and send them to everyone if that's of interest, because certainly it's interesting to see what people, lack of political leadership, and we hear a lot about leadership, evidence, partnership engagement, people fall through the cracks, silos, accessibility to the target population. That's interesting because I've been doing some reading and learning around community engagement and how to do that. Lack of political will. This is really great, everyone. This is really, really rich. Thank you very much. I am going to close it, but if you've got more to offer, put it into the chat box, and if it's of interest, we can share the results. So this is really neat. Hey, Martine, I'll turn it back to you.
Yeah, it is, and I hope that some of what I'll be presenting will help us reflect on how you can better address these challenges, and maybe we can come back to them at the end of the webinar. So thank you so much.
Yes.
So now in the next few minutes, I'll go through each of the more classical entry points for intervention. I'll describe what a classic intervention might look like, as well as their advantages and shortcomings. I'd like to mention beforehand, though, that for the sake of this presentation and for illustrative purposes, I've had to simplify things a bit, and so I try to distinguish the different entry points in a way that might seem artificial. So we need to keep in mind that in reality, and as practitioners, you can probably speak to this even more than I can, the boundaries between the entry points and the resulting interventions are really not as clear-cut as my presentation might suggest, and there might actually be some overlap and some interrelations between them. So just keep that in mind. So a first popular entry point is issues and risk factors. So this might include diseases, risky behaviors, or even conditions such as homelessness. The main objective of interventions that target issues and risk factors is to reduce the prevalence of these diseases, behaviors, and conditions. And this is generally done by providing information and health education to improve the health literacy and to develop personal skills in individuals. So this approach is rooted in risk factor epidemiology, which is concerned with identifying some modifiable biomedical or behavioral risk factors that contribute the most to the burden of disease. It's also rooted historically in health education and in the individual level health theories that were predominant in health promotion. So a very good example of an intervention that was based on issues and risk factors is the Mr. Fit intervention trial, which was done in the 1970s. So this trial involved 6,000 men that were at the highest risk for cardiovascular diseases. It was a very well-funded intervention. It used the best behavior change techniques available at the time. But despite all of this, the results were not very satisfying. After 6 years, there were still 62% of men that were smoking, and 50% were still hypertensive. So this example is a very good illustration of one of the main shortcomings of targeting issues and risk factors when developing interventions. The gains may be short-lived, especially at the population level, because there's always new individuals that are going to be adopting those behaviors that we're trying to eliminate in the first place. And this is probably because the factors and the mechanisms that put people at risk of risks are not taken into account. So in other words, the individuals and their behaviors are not considered within their wider social context, which might involve such things as industry tactics, community norms regarding healthy eating or smoking, and the socioeconomic circumstances within which people live. So a second entry point is populations and specific groups. These are generally characterized by shared key characteristics which are believed to put them at risk of suboptimal health or at risk of specific conditions. So we might think of women, children, the elderly, or indigenous communities. Again, the objective of interventions targeting specific populations is to improve the status of these groups, and this is normally their health status, but not their social status. So one could think of reducing child obesity, for instance, by designing interventions tailored to children per se. So as with the former approach, interventions often consist in providing education, information, and in developing personal skills in individuals. So some of the advantages of this approach is that it fits how organizations and funding is generally set up. So we can think about the CIHR Institute for Indigenous Health, for instance, that funds research specific to these populations, or for centers for maternal and child health. Regrouping people in specific populations and groups can be beneficial because it helps them understand how multiple risk factors might cluster within specific groups. However, this approach tends to favor, again, a high-risk approach and to target one single issue or risk factor at a time in one specific population. Here again, the social context of health and intervention is not really taken into account. What makes a group more vulnerable to a host of issues and risk factors in the first place is not very often considered. So Frolic and Potvin have suggested turning to the concept of vulnerable populations instead of at-risk populations, where a vulnerable population would be defined based on their sharing similar social circumstances rather than similar social risk factors, So these defining social characteristics would lie in the conditions and the relationships that determine a group's position in the social hierarchy and which would make them more marginalized and disadvantaged compared to other groups. So coming back to the example of indigenous peoples, if we were to view them as a vulnerable population instead of an at-risk population, we would better understand that it's their shared history of colonization and marginalization that has had the psychological, physical, social, and spiritual consequences that we know of today. And our third entry point are settings, or the places where people live, work, and play. These can be schools, workplaces, neighborhoods, or even virtual spaces. So there are two different conceptualizations of settings that have emerged in health promotion practice, and the interventions based on each of these conceptualizations may be different. So I've described them side by side in this table and the following one so that we could compare them. So on one hand, on the left-hand side, we have the more traditional conceptualization of settings, which I would call the narrow version. It views settings as physically bounded containers with a clear organizational structure. The objective of interventions based on this definition of settings is to reduce the prevalence of diseases or risky behaviors among populations that are found within the settings and that are seen to be quote-unquote captive of a given setting. This kind of intervention has traditionally involved, again, health education or mass media campaigns to develop personal skills targeting individuals. On the other hand, there is a less common, broader conceptualization of settings, which views them as more loosely bounded and interrelated. So this is based on an ecological model of health, where different settings, such as schools, workplaces, and neighborhoods, for instance, would be seen as interacting with each other rather than being isolated from one another. Interventions based on this definition of settings would aim to make the setting more health enhancing as a whole. So through changes such as physical, organizational, or policy changes that seek to change the structure of the setting itself. And this could be combined in some cases to more individually targeted interventions that can help individuals take advantage or benefit from the more structural changes. So an intervention based on the narrow definition of settings would be to provide nutritional education programs for kids in schools, for instance. On the other hand, under the broader approach, this educational program would be combined to providing cooking classes, serving healthy foods in the cafeteria at lunch, and organizing a farmer's market to make fresh fruit and vegetables more easily available to the community at large. So the narrow definition of settings has some advantages, as it can allow practitioners to reach a wide audience at once, and it also allows practitioners to retain some kind of control over the intervention, so what's delivered, how, and to whom. However, it again usually targets one issue or risk factor or one group in one setting at a time. And the gains may not be maintained beyond these settings boundaries. So they may be short-lived as well. On the other hand, interventions based on the broader definition of settings are fuzzier and a lot messier, but behavior changes tend to be more sustainable in the long term because new individuals moving into a healthy setting may benefit from the changes already made. It's also been suggested that interventions based on this definition, so the broader definition of settings, have a greater potential of reducing health inequities when they target both the setting structure as well as the individuals found within that setting. It's nonetheless very difficult to harness settings in their full complexity, and I think that has come up in the previous poll. And this might explain why this perspective is not as widespread in practice as the narrow one. An additional shortcoming is that it's rarely informed by a deeper social analysis of how health and health inequities are produced and reproduced within settings. So I'll just present a more concrete example of an intervention that was inspired by the broader definition of settings. This is the New Deal for Communities Urban Regeneration Program, which took place in the UK. It was a very large, very expensive 10-year strategic plan to transform 39 of the most deprived neighborhoods in the UK. And the ultimate goal of this intervention was to bridge the gap between some of the most deprived neighborhoods in the UK and the rest of the countries in 5 outcome domains. So not only were they targeting health, they were also targeting unemployment, education, crime, housing, and the physical environment. So each neighborhood had some money to implement individual and area-focused interventions that were tailored to their needs, their resources, and their own reality. So an evaluation of this program found that there was a reduction in inequalities in mental health and life satisfaction over time. However, in the neighborhoods that received the intervention, there was also a widening of inequalities. in long-term limiting illnesses as well as in smoking cessation. So in the case of smoking, there were further studies that reported that the most educated residents in those neighborhoods receiving the interventions had likely benefited most from the quit smoking program. And they had quit smoking in greater numbers than the less educated residents. So it seems that the intervention, although it was very well defined and implemented, might have missed its intended target, possibly because it did not accurately account for the less educated smokers' social reality and to the social context in general. So now another polling time. If you'd like to tell us what entry point or entry points that I've discussed so far you have used in your health promotion work.
And if there are other entry points people have used, not the first four, if you can put that into the chat box, that would be really interesting, because I know that we've all practiced on really different levels, and I know that we've all had really different strategies, so there may be other entry points, other perspectives that we've not thought of. So please do enter that in. It's interesting because a lot are saying issues and risk factors, and then population groups, and then settings. And I had just commented in the chat box that I felt like settings was the most common one, and it looks like it is if you look at narrow and broad settings together. Then when it comes to public health, we do a lot of our work that's settings-based. That's interesting. It's pretty closely tied with issues and risk factors, but less about population groups. That's really interesting, everyone. Are you surprised by that at all, Martine? Or I'll end, but please do fill some things into the chat box. Are you surprised by that?
I'm not really. I think the issue and risk factors one tends to be the more common one. But they all interact and intersect, so it's hard also. There's probably people who use a combination of these entry points in one same intervention, so they're hard to keep apart from one another.
Yeah, okay.
Okay, so I'll keep going.
Yes.
Yeah, so just to synthesize, the overall shortcoming of these entry points that I've just discussed is that they each in different ways fall short of taking into account the social context of intervention and of addressing the full complexity of how individuals and their social circumstances interact to produce health and health inequities. So some approaches overemphasize the individual and the agency that they have in making healthy choices, while others overemphasize the environment and the social structures and opportunities that it provides. The problem is that these things tend to act and interact together. And the related shortcoming is that these entry points do not really allow us to fully understand how health inequities are produced and reproduced, because this requires that we focus on mechanisms instead of on contextual factors only. So a promising approach which could help us better harness the social context of intervention as we've defined it previously is the collective lifestyles approach. So the collective lifestyles approach was developed by Kate Froelich, drawing and expanding on current sociological theory. It explicitly situates behaviors within the broader social structure, and it views behaviors as a collective object rather than an individual lifestyle, hence the collective lifestyles term. So while this approach is similar to the socio-ecological approach to health, it has several specificities that we think are particularly relevant to helping us overcome some of the challenges that I just described. So first, it moves away from individual level theories towards current sociological theory to, I'm missing some animation. Oh, there's something wrong with the diagram on the right, I apologize. It should say social structure. In the middle, the box should say social inequities in health, and the lower box should say agency. So the collective lifestyles approach views social structures, and these include norms, resources, and policies, as shaping health behaviors, which are called health practices in this approach. And health practices further shape the social structure. So it highlights the collective nature of behaviors. We see the opportunities that individuals have for healthy behaviors as being shaped by their social position. There's also a very central focus on an explicit recursive relationship between what people do and the structure within which they are acting. A second characteristic of the collective lifestyles approach is that it accommodates thinking about not only health practices or health behaviors, but also social practices more broadly. So it allows us to frame social inequities in smoking, for instance, as being derived from inequities at the local level in the ability that people might have in complying with tobacco control legislation. Compliance, in this case, would be considered a social practice rather than a health practice. Another example would be viewing inequities in physical activity as coming from inequities in local norms regarding park use, in cases where park usage may be more acceptable for some social groups than others. So this type of thinking helps us move further up the causal chain, if I may say. A third and related characteristic is that it sheds the focus on structural constraints and opportunities for agency and behavior change. So it understands that creating opportunities by making the structure or the environment more conducive to health is not enough. People need to be empowered and enabled to make use of the changes or to comply with them. So in one paper, coming back to the smoking example, in one paper by Hargreaves and colleagues, for instance, they found that the UK-wide smoking ban in public spaces had a differential impact on smokers depending on the local norms that were at play where they lived. So some smokers reporting being able to quit, partly due to the ban, while others couldn't even try to quit, or some also relapsed as time went on. So the structural opportunities for change in human behavior are not always experienced in a uniform manner. And it also recognizes that individuals have the agency to overcome constraints. So for instance, coming back to the park use example, in one paper, the authors found that residents of the neighborhoods that did not have very high quality parks and green spaces were actually not affected that much by it because they were able to drive to the nearby beach or go further afield when they wanted to spend time outdoors. One thing we need to keep in mind, however, is that this capacity to overcome structural constraints is itself not equally distributed among social groups, and it may contribute to health inequities. A fourth characteristic is that central to the collective lifestyles approach is a focus on power relations. So it recognizes that power relations shape the social distribution of health behaviors and outcomes among groups, and that it also creates the social structure that sustains these behaviors in the first place, and that sustains the inequitable distribution of opportunities and constraints that different groups face in adopting and maintaining the behaviors that we're interested in. And a final characteristic that's related to the one on power relations is the importance of reflexivity for health promotion researchers as well as practitioners. As researchers, I speak for myself, and as practitioners for you, we need to see ourselves as active participants in the social context, and we need to realize that we have the power to influence what is studied and acted upon and how things are done, because we have the ability to favor one or the other of the entry points that I've just discussed. And knowing this, in order to remain reflexive in our work, we would recommend maintaining a self-critical attitude and also questioning the assumptions that we generally take for granted in our work, especially with regards to its political nature. We should also try to foresee the intended and unintended consequences that our work has on health and health equity, as well as try to think about the social distribution that, of the impacts that our work might have. So maybe we could go quickly to this polling. Dianne, yeah?
Yeah, it's there, ready to go.
So if you want to tell us a bit about how could these key characteristics that I very quickly described to you of the collective lifestyles approach, how could they be integrated into your own health equity work? You can write down your answers.
Yes, it's a text entry one, similar to what we did before. Maybe people are stumped.
I had to go very fast.
Yeah, no, it's okay. Lunch and learns, advocating for healthy public policy, helping influence dominant culture. Always asking who is participating and not just the total numbers. And that's a very interesting one.
Yeah.
And, the who. So who is participating? And we sometimes say, who is at the table? Another question and another way to look at that is who is not at the table and what is preventing them from being here? And that takes it to more of a social justice type of lens, which is a little further than just the equity lens. Not further than the equity lens, but a different slant, right? Critically considering who our key stakeholders are, who is left out, the distribution of the impacts of policy, how do we influence that dominant culture, and beyond the organizational constraints, because that's a reality of all of our work, is that there are organizational constraints, whether it is budget, whether it is resources of other sorts, whether it is willingness and intention. There are going to be constraints, and often at an organizational level. So within that, what can we do and what can be done? Addressing agency and empowerment, and that's something I'd actually like to hear a bit more about in the Q&A, and I know we're going to hear from Amanda about that as well. Better understanding of the social context. So this is really great. This is really good. This is really good information for me to consider in our work going forward here. So yeah, thanks everyone. If you've got more thoughts, put them in the chat box.
Thank you.
Okay.
So just to conclude quickly, so I know the collective lifestyles approach is not necessarily an easy one or a straightforward one to apply in practice, but I think that its key characteristics can serve as a good starting point or a good guide to ask the right questions when designing and implementing interventions. I also hope that this presentation has convinced you of the important role that you have as practitioners in being explicit about the entry point that you choose to focus on and why you choose that entry point instead of another when you develop your interventions. And I also hope that I've conveyed how each entry point has some shortcomings and how to overcome them, and that you'll try or keep doing it. You'll try to anticipate the consequences that focusing on one rather than the other may have on health inequities in your specific context and in your specific situation that you're working with. So, thank you.
Great. Oh, thanks, Martine. That's
You're welcome.
Really, really excellent. I am going